5. Oh, was I muted? Oh.
So, you want to? Yep, start your intro again.
Okay, let's start the intro again. So,
I don't know.
Yeah, we won't re-click through. So my background is in social sciences. I have a bachelor's in anthropology. My MPH is in epidemiology from U of M. I also pursued doctoral studies at U of M, but did not complete all but dissertation. I've taught several classes, including introductory statistics and biostats and epidemiology for non-majors. So this kind of discussion is really familiar territory for me. I currently work as a child and adolescent health epidemiologist at LMCH, where I provide epidemiological and statistical support to a variety of programs that are probably relevant to folks on the line, including Title V, child and adolescent health centers, and school hearing and vision. And there's going to be a lot of these little comments. Feel free to peruse them as you as it starts to get a little dry. So, okay. So today we'll be covering why work with data, some possible data sources, basic statistical concepts and terms, basic epidemiological concepts and terms, and then using data in your work, ways that you can integrate these concepts into your work. But the very first thing is throughout this presentation, you will be hearing me use data as a plural form. That's because data is the plural of datum. This, if you wish to impress your epidemiologist and statistician friends, say things like, these data are, these data show, and not the data is, the data shows. We have had this brutally trained into us from day one. We cannot change. This is just how we are. So when you hear the data are, that's not me misspeaking. That's just epidemiology brainwashing. So why work with data? Well, typically, non-data professionals have a number of interactions with data, including collection, reporting, and review. So you might do things like collect the data in clinic, collect administrative data, then report that data to your funding agencies, to the state or federal government, to various fiduciaries for your own internal usage. And then you might need to review data from a variety of sources for clinical decision-making and for quality improvement. So one of the ways that we work with data is research, which includes seeking answers to specific bounded questions. So not questions like, how do we prevent pregnancy in adolescents, but things like, does offering no-cost hormonal contraception on site increase hormonal contraception use among our facility users compared to the previous year? That's much more akin to what a research question would look like. It can be done with existing data sources. It's not always necessary to do primary data collection in order to conduct research. And the work of research is actually, it's straightforward and tedious and repetitive and also, but can be complicated in the details. But the overarching work is you generate a research question, the more specific, the better. You come up with some sort of methodology designed to answer that question. And that methodology would address what data do you need to directly answer your question, what data do you need to make sure you're not accidentally measuring something else. So for example, you might want to collect data on race, gender, and age to make sure that your data isn't biased, your data sets aren't biased in such a way that you're actually capturing the effects of being an older woman, for example, versus whatever is your actual exposure of interest, and then how to analyze those data. An epidemiologist can help you with this. You can reach out to any of your program epidemiologists, and they can help you design and set up a research study. And then you analyze your data and report the results. This doesn't have to be complicated. Excel has a number of basic analytic functions that can be used. You don't need to get into the realm of multi-level, multivariate regression models. You can do simple things, and we'll get into what some of those simpler analytic functions are. And you don't need to publish it in a journal. Using it within the office, doing a poster presentation, publishing a white or a gray paper, for example, government documents on MDHHS websites. These are all valid ways of reporting research results. Another reason we work with data is for evaluation purposes. And evaluating whether a program or intervention is effective at doing what it's meant to do is crucial for ensuring that our participants are well served by our programs. This is an extremely heavily data-driven process, and data comes in at pretty much every stage of the evaluation in an evaluation. So you have needs assessment of finding out what your populations need, theory assessments, are your goals feasible, well-defined, and responsive to the population's needs, implementation, are you reaching the people that need reaching with the services they need, impact or effectiveness assessment, has the target population changed in any way as a result of our program, the efficiency, which is your cost-benefit ratio, and this should be a holistic practice, each step relying and building on the work done in previous steps, so your data will come in from the beginning and sort of feed through the whole process. What data are needed and how to collect them should be developed long before it's time to evaluate effectiveness and efficiency, in other words. Another reason, which I'm sure you're all familiar with, is continuous quality improvement. This is the PDSA cycle that I was told is commonly used in a lot of your sites. So CQI is the iterative practice of evaluating current practices for potential sites of improvement with continuous monitoring and reevaluation. And like research and evaluation, data play a role in each step. So when you're doing your planning, you're assessing needs and outcomes from previous cycles. You do that by assessing your data. When you implement your changes, then you observe, document, and analyze the outcomes. You're collecting data. When you study those changes, you're reading through your reports, trying to determine whether things have worked as they were intended to. And then when you actually make modifications and begin the cycle again. So at each of those steps, you're considering what data are needed, how do we use them, and trying to make it as holistic and integrated as possible in order to reduce time in the final steps. You know, you have those data at hand, you can use them going forward. So some takeaways. We work with data because data provides information that allows us to better serve our populations of interest. It's best to develop data collection and analysis plans from the beginning and integrate it throughout the life cycle of a project. It's not hard to do, but it does require some thoughtful planning in the beginning to make it easy for the rest of the process. So in the next sections, I'll talk about some things to consider as you work with data, what types of data to collect or use, some basic analyses, and how to interpret results. So I'll start with data sources. Data can come from a wide variety of places. The four main types of data sources we'll be discussing today are research data, surveillance, publicly available, and routinely collected, aka administrative data. These are not mutually exclusive categories. Data can be routinely collected via surveillance and made publicly available. Two other important data terms to bear in mind are raw data. These are typically unprocessed individual level data. Raw data typically will have some errors, formatting issues, weird omissions, and so on, that would then be cleaned in a data management process. There we go. And then aggregate data, which summarizes individual level data into groups of interest. For example, all Michigan residents, males or females, persons above or below a certain age, racial ethnic groups, etc. And aggregate data may also require suppressing some categories according to organizational rules. For example, vital records data suppresses any aggregate group with fewer than 6 observations. So if you're working on American Indian teens, you may not be able to report those data from vital records for a single year because you may have fewer than 6 that meet all of your requirements. Surveillance data collection is typically a continuous systematic collection, analysis, and interpretation of health-related data needed for the planning, implementation, and evaluation of public health practice. It's typically mandated by law or regulation. There's two major varieties, passive and active. So passive is typically reported to public health agencies by healthcare providers. Examples of this include vital record documentation of birth and death certificates. The pros of this approach is that it's relatively simple and inexpensive to do. The cons are that you have incomplete data of uncertain quality. So you do miss out on people who are not visiting healthcare providers who are actively reporting their information. So in the case of birth records, you may miss out on home births or have midwives that delay reporting their births for a period of time. Active surveillance is when health agencies seek out data from healthcare providers and the public at large. This is often done in the event of infectious disease outbreaks or environmental health hazards. The pros are more complete and standardized reporting, as the agents are out there actively collecting data and will have a standardized format for reporting. The cons are that it's much more expensive and time-consuming than the passive approach. But irrespective of how data are collected, it should always lead to action from public health agencies, whether that's just descriptive reporting, for example, the birth rate in the state of Michigan for a given year, monitoring trends and patterns in disease and risk factors, providing data to programs and policymakers, or evaluating prevention and control efforts. Surveillance data are usually collected by government agencies, so CDC, MDHHS. They can be collected by universities or nonprofits, but that's typically in collaboration with a government agency. If surveillance is done right, those data will be broadly representative of the underlying population of interest, assuming that there's little to no regional, racial, ethnic, gender, et cetera, disparities in surveillance of the conditions of interest. So if you are relying on healthcare providers in areas where there are few healthcare providers, you may have issues with having up-to-date, accurate surveillance data. Also assuming that your active surveillance has a large enough dragnet, so you're not accidentally omitting potential cases of a disease, for example. Surveillance is not typically tailored to answer a specific question. For example, a certain infectious disease diagnoses are reported in order to detect potential outbreaks, but not to determine whether some specific thing is putting people at increased risk. So we do monitor, for example, STI cases, but not necessarily whether condom use is down and causing those outbreaks. Trying to determine the cause typically comes a bit later in an outbreak investigation, which we'll not be talking about today. Surveillance data are often made publicly available in at least an aggregated form. Individual level data may be available on request, but that typically requires a data use agreement, institutional permissions, et cetera, et cetera. Administrative data are generated at the time of provision of healthcare services, hospital admission, or discharge. They contain information about primary and secondary diagnoses, procedures performed, and medications received. They're often linked to demographic data, for example, age, sex, race, and also especially insurance status. They do not typically include information on test results of any kind, laboratory, radiology, or other clinical measures, and are typically made available from insurers, including private payers, Medicaid, Medicare, and the VA. The pros of administrative data are that they're quite low cost to obtain, and with potentially widespread population coverage, especially as increasingly large proportions of the population do have insurance coverage. The cons are, well, they're questionable accuracy. These are typically billing documents, so people are reporting diagnosis and procedure codes for what gets paid, not necessarily the most accurate diagnosis for a condition a patient is reporting with. Limited information is available, so we don't have those laboratory test results, and these data are not generated to answer specific questions. They're generated for maximum billing effectiveness. But administrative data are used in a variety of health initiatives, such as Healthy People 2020, which uses data from the National Hospital Discharge Survey, which is useful because it helps to highlight geographic and racial differences in the provision of healthcare, and the Health Plan Employer Data and Information Set, aka HEDIS, which uses which is done to ensure quality from various HMOs. And research data is data collected by research surveys, observational studies, or experiments. These are often publicly available only in aggregate form if they're publicly available at all. So this can include things like tables and charts in publications, but there is a growing movement among researchers to make their data more usefully available rather than just in tabular format in publications. So they may be able to share clean, suppressed data either publicly or with interested researchers, members of the public, other stakeholders. This also depends on a whole lot of alphabet soup issues, IRB, so research ethics boards, or data use agreements, and so on. Data are tailored to answer specific questions about specific populations and may not be generalizable to your population of interest. So for example, a sexual health education program that was successful in rural Greece may not be as useful in Detroit public schools. And again, and really what needs to be borne in mind here is that data are only as good as the design of the study. A poorly designed study is poor quality data every time. Publicly available data. Now, these are going to be among the most useful categories of data for people trying to integrate data into their regular day-to-day work. These are most often made available from government organizations. Publicly available data are typically aggregated, although not always, clean, although not always, and a few years out of date. And that's basically always true, because it takes time to aggregate and clean the data we collect. The pros are that publicly available data are free, simple to access, downloadable in multiple formats, and sometimes come with snazzy online tools so you can run basic analyses without having to figure out weird Excel functions or do statistical programming. The cons are that the data are older. They may not provide precisely the information you need. So you want data on 15 to 19-year-olds. The publicly available data set reports on 13 to 19-year-olds. And then the data are often suppressed for low population areas or low population groups. So again, if you're working in Michigan data, you want data on the Asian American population. That might be too low of a population for certain outcomes. So before we get into the next section, I just have a brief aside about survey data in America in the 21st century. Surveys are an extremely important tool for just about every type of data collection, any surveillance, research, etc. However, and really unfortunately, survey response rates have plummeted over the past few decades because, well, privacy concerns tend to top that list. People report feeling over-surveyed. People have caller ID on their phones and they do not answer calls from numbers they do not know, which is very rational, makes a lot of sense, but is unfortunate for survey design. And survey researchers have been employing a wide variety of tactics to improve rates and or appropriately weight respondents to better represent their population of interest, but you should still be aware of surveys with a small number of respondents or really high margins of error. You should also be aware of survey items that got low response rates and otherwise high response surveys. These are both indicators that the data may not be adequately generalizable or representative of the population at large. You should think carefully about who was surveyed and how. So for example, if this is a survey of teenagers and they did a landline survey, that is, they did not include cell phone users, you might want to question how representative those data about teens with landlines are. So this is basically a prologue to my next few slides, which are all about surveys. So some useful and good publicly available data sources include the American Community Survey and the US Census. You can find those data at these links. So both of these contain data aggregated at a variety of geographic levels. So think census tract, county, zip code, state, country, for a wide array of socioeconomic, demographic, and other indicators. Small population groups and areas should use 5-year ACS or older census data due to the Census Bureau's data suppression rules. Data can be downloaded, analyzed, mapped, or simply reported as needed. For example, if for a needs assessment you need to report a certain percentage, ACS data is available for that. Another good publicly available data source is the Youth Risk Behavior Surveys from CDC, YRBS. These provide individual responses at the state level and aggregated for Detroit to provide survey items from samples of adolescent high school students. These include items on sexual behavior, diet and exercise, drug, alcohol, and tobacco use, family life, bullying, and so on. If you're not a data person, if you're not into doing your own analysis, YRBS does have a handy tool, the Youth Online Analysis Tool, which will provide state-level results by year, race, grade, sex, sexual orientation, and identity. But if you need analyses based on something other than those factors, that does require some statistical coding knowledge. For example, if you'd like to see whether respondents who ride in cars without seatbelts are different from those who always use seatbelts when it comes to sexual behavior, that would require a statistical software package to do that analysis. This is not something Youth Online can do. Your neighborhood-friendly epidemiologist might be able to help. Woo! Finally, another good source is the MDHHS Vital Records site. So I've included the link for birth data here. There is also data on on mortality. There's data through the STI departments on cases and rates for different population groups throughout the state and at the county level. Aggregated data are available by year at the city, county, local health department, and state levels. A wide variety of variables are included in the birth data, such as demographics, socioeconomics, health risk factors, and then outcomes. You can look at different groups based on race, age group of the mother, prenatal care, birth weight, and weeks gestation. Unlike YRBS, the individual level data are not publicly available, so you can only access the aggregated data from the public-facing websites. Analyses that cannot be done through vital records sites do require making data requests to your program epidemiologists, who'd be happy to run those for you. Okay, so now that we know what data are out there, now we want to run some stats on those data to see what they're trying to tell us. So what is statistics exactly? Well, it's a science that deals with the collection, analysis, interpretation, and presentation of data. In public health, we're usually trying to understand a population, which is a sort of ideal, not theoretical construct of all the people who meet a given construct or a given criteria. But since it's hard to get data on literally everyone, we typically rely on samples, a portion or subset of the population of interest, to make inference about that larger population. A statistic is a metric derived from sample data and is an estimate of the population parameter, which, like population, is a more theoretical concept. So for example, our population of interest might be every Michigan resident. Our sample are residents in Michigan, in 10 Michigan counties. The parameter that we'd be interested in is the average age of all Michigan residents, and our statistic would be the average age of the residents in the 10 sampled counties. This is a very simplified example of how that would work, but it's just to give a little bit of insight into how those processes how these processes I'm about to describe came to be. There are two major types of data that statistics relies on. The first is categorical or qualitative data. These include characteristics that cannot be defined numerically, meaningfully numerically, such as gender, marital status, city of residence, ethnicity. Categorical data have limitations for what kinds of analysis can be done. They're more often used to stratify numeric data into different groups rather than used as the analytic piece as such. For example, we might be interested in breastfeeding initiation rates by different ethnic groups. So we would stratify those breastfeeding initiation rates by the different racial groups. The other major type of data is numerical or quantitative data. These include characteristics that do have meaningful numeric definitions, such as height and weight, age, income, and these come in two major forms, discrete and continuous. Discrete data are counts. There are no possible decimal values. So the number of live births is a discrete variable. There are no half babies born that are live. Continuous data are measurements that where decimals or fractional values are possible. So weight would be a continuous variable. You can weigh 8.5 pounds, 200.1 pounds, whatever. A special case is ordinal data, which are an ordered series of relationships or ranks. They're sort of like a weird middle ground between categorical and quantitative data. Likert scales are a really common source. So, on a scale of 1 to 5, on a scale of very strongly disliked to very strongly like, and those have their own set of analytic requirements that I will not be going into today. So now we know a little bit about what data are. So we'll talk about some important kinds of statistics. Statistics is broken into two major categories, descriptive and inferential. The following are all considered descriptive statistics. Measures of central tendencies are ways of summarizing data sets into a single metric, such as the mean or the average, the sum of all measurements divided by the number of observations, which can only be used with numeric or ordinal data. It's sensitive to the presence of outliers, values that are much higher or lower than the other values in a data set. So if you think about you're in a room, you're trying to get everyone's average income, and you have a good number, and then Bill Gates walks in. That number is going to swing really high as a result. The average might be higher than everyone else in the room because Bill Gates walked in with an extraordinarily high number that isn't in line with the rest of our data set. He would be an outlier in our income data set. Another option is to use the median. The median is the middle value that separates the higher and lower halves of a data set. It is not sensitive to the presence of outliers. Adding Bill Gates to the group when we're doing the median would only shift the median by one value higher, because we'd be adding one additional person. The mode is the most frequent value in a data set. It can be used to summarize categorical data. For example, how many, what were men or women more common in our data set. The other type of descriptive statistic is dispersion, which are the measures of the spread of values in a data set. Range is the difference between the largest and smallest values. It's not typically used all that often, since it's sort of not informative unless you also know what those largest and smallest values are. Variance and standard deviation are both statistical measures that try to get at what the average distance is of values from the mean of the set. Those you can calculate in Excel, but are just sort of ways of communicating how different each point is from its own mean. One thing that we see come up a lot in different reports from programs is confusion of relative and absolute percentage change. So absolute percentage change is just the simple difference in percentage between two groups or two times for a given indicator. The unit here needs to be explicitly clear that you're working with percentage points. Relative percentage change expresses the absolute change as a percentage of the value for an indicator at time 1, or for group 2 relative to group 1. The unit here is the percentage, and it's calculated by subtracting time 1 from time 2, then dividing by the value at time 1, or similarly if you're working with two separate groups rather than two separate time points. It's typically a lot more useful to report the relative percentage change. For example, an increase from 5% to 10%, or an increase from 85% to 90%. Both represent a 5-point increase, but one is a much more significant increase, which can be captured by calculating the relative percentage change. So for the 5 to 10% group, this is a 100% increase in whatever our indicator of interest is, whereas the jump from 85 to 90% is only about a 6% increase given the baselines of our population. So just a quick example using real data. So from 2016 to 2017, the percentage of births to mothers ages 15 to 19 that were repeat births in the state of Michigan, in 2016, that was 17% of all births to mothers ages 15 to 19 years, and in 2017, it was 15.9%. So first we would calculate the absolute percent change between these 2 years, which would be a 1.8 percentage point decrease. This would be interpreted as the percentage of births that were repeat births to mothers ages 15 to 19 dropped by 1.8 points from 2016 to 2017. Calculating the relative percentage change over that same period, we take that 1.8, 15.9 minus 17.7, and divide by 17.7 to find that it's actually a 10.2% relative decrease. This is interpreted as the percentage of births that were repeat births to mothers ages 15 to 19 years dropped by 10.2% from 2016 to 2017. All right, so now moving from the realm of descriptive statistics to inferential statistics, we talk a little bit about statistical hypothesis testing. I'm going to take a second. Okay, in statistical hypothesis testing, our final aim is to determine whether the difference we're seeing between two or more variables is greater than what we would expect from chance alone. These are inferential statistics. We're trying to disprove the null hypothesis, which is often a statement that there's no difference or no change between two groups or among groups over time. The alternative hypothesis is most frequently a statement of what the null hypothesis does not equal. So for example, if the null hypothesis is that a coin has a 50% chance of flipping heads, the alternative would be that the chance of flipping heads does not equal 50%. The result is statistically significant when we reject the null hypothesis because the distribution of our data is sufficiently different from the distribution of expected values if the null hypothesis were true. I'm 100% not going into the details of this, I swear. I just needed to let you know the definition. It's not just a magical number that comes out of nowhere. It has to do with distributions of values. This is an extremely brief nod to data and probability distributions, but I would like to highlight that this is a real puzzle that I actually did give to my own child. my first univariate distribution. Like, the brainwashing is real. So inferential statistics is based on the comparison between the distribution of actual data and mathematical probability curves. So all of these univariate distributions are probability curves. Each probability distribution comes with its own set of assumptions about the nature of the data you've collected. Using the wrong distribution to assess your data will give you wrong results every time. This is another opportunity to reach out to your friendly neighborhood epidemiologist. These allow data scientists to determine whether and to what extent our actual data represent something different from what would be expected from random chance alone. So I've drawn this very excellent curve that's extremely mathematically accurate in all ways over the normal distribution here. And so these, assuming that our yellow line here is our actual data, we would then compare it to our normal distribution to see whether this distribution of data is significantly different from what we would expect under the normal distribution. This line here represents one standard deviation of difference. So our mean here is one standard deviation different from whatever would be assumed if the null hypothesis were true. And whether or not that's a statistically significant difference would require actually doing, probably a t-test or something, but or a z-score test, but we're not going to talk about that too much. But that's just how it's done, is you compare, these are our actual data, this is what's expected if the null were true, we compare the means, and then we compare the distribution as a whole. So what does statistical significance mean? Well, so when somebody's reporting a statistically significant difference, they're typically relying on the p-value, which is calculated after comparing the null, producing a test statistic, and that's it. That's all I'm talking about with this. For very arbitrary historical reasons, the agreed upon cutoff for statistical significance is a p-value less than 0.05. What this actually represents is that there is a less than 1 in 20 chance that our data are consistent with the null hypothesis, given that the null hypothesis is actually true. The smaller the p-value, the lower the probability that the null hypothesis is actually the correct hypothesis. A low p-value does not in itself prove that an association between an exposure and an outcome is real or clinically important. There are, of course, issues with study design, sample size, and effect size. So p-values are extremely dependent on sample size. In very large samples, very small differences in effect size. So for example, a medication that lowers blood pressure by 1 millimeter of mercury will come up as significant as p less than 0.05, even if to a clinician that's an irrelevant measure. And similarly, a very large effect size in a small sample will also likely trigger a significant p-value. Assessing trends. So a trend is an upward or downward shift in data over time. This is something that a lot of different organizations are interested in. How have you improved over the last few years? How have things gotten better or worse? Trend analysis quantifies and explains trends and patterns over time in our data. For reasons related to sample size, I do not approve of trend analysis with fewer than 5 years of data. You can do other comparisons if you only have a couple years of data, but you can't really do trend with fewer than 5 years. The eyeball test, just looking at your plotted out data, can suggest whether data are trending in one direction or another. Formal statistical tests are needed to determine whether that trend is significant, and that's often required by different reporting agencies. This does require use of a statistical software package, such as SPSS, R, Stata, or SAS. I believe that you can do it in Excel if you have the stat pack, but I do not have Excel with the stat pack, so I cannot get into it. These tests can include all these famous statistical men's names, followed by a test name. But those are the things you would look up if you were going to do it in one of these software packages. Excel will produce a trend line with its trend function, but it does not include information about whether that trend is statistically significant. It's just sort of an average straight line across messy data. If your office does not have a statistical programmer or software package, you know who to reach out to by this point, I'm sure. So that's statistics. Epidemiology builds on and uses statistics to answer questions about human health. So basically, epidemiology is the study of the distribution of disease and its risk factors in a population. Some basic terminology. Outcome is a broad term representing the disease, state of health, condition, etc. of interest. The exposure is a thing that may affect the risk of developing the outcome. And exposures and outcomes are neither good nor bad. They can be either. So your exposure might be something nice, like taking vitamins or exercising or something like that. At risk is a term used to describe any person who does not currently have a disease but could potentially develop it. So for example, someone who's been vaccinated against measles might not be at risk because they are not they're not at risk of developing it. They will not potentially develop it, even though they do not have it. Epidemiologists use measures of occurrence like prevalence, the proportion of people with a condition at a single point in time. This only tells us the proportion. It does not get at the risk of developing the disease. It just lets us know what slice of our population are experiencing this disease. Prevalence here is represented as the water in the tub. Incidence measures the occurrence of new cases of a disease over time. Incidence is represented by the faucet pouring into the tub. It can describe the risk of developing a disease, but these data are much harder to get at than prevalence data. We also look at things like counts, ratios, and rates. Counts are the most basic unit in epidemiology. The number of cases of disease or occurrence of other health events, for example, live births, are counts. Counts are also useful for demonstrating the magnitude of a public health issue, but by themselves, counts cannot describe risk of a given health outcome. For that, you need a denominator. Ratios are the relative magnitude of two values, calculated by dividing one count by another. So for example, you might be interested in figuring out whether males or females are at higher risk for a certain outcome. Proportions are a special class of ratios where the numerator is included in the denominator. So you'd be looking at all people and trying to figure out which percentage of those people have a given disease or condition. You would report a proportion with a percentage if the count is sort of sensible over a denominator of 100. For example, there's more than one case per 100 people. People just don't really readily get the 0.0001%. So where there are fewer than one case per 100 people, it may be necessary to report larger denominators to get more meaningful numbers. So for example, one case per 1,000 or 100,000 people is just a little bit easier for folks to understand. And you'll see that with like birth rates, death rates, et cetera. Proportions are used to summarize prevalence data. Rates are the frequency that an event occurs in a defined population, and this is important, over a specified time period. The time piece is really important. So just like when you're driving, your speed is reported in miles per hour and not just in miles, that's the same thing that's going on when you see an epidemiological rate. So counts of new diagnoses or events are divided by the population at risk for those conditions over a set period of time. So consider the following. 100 cases of flu occurred in pregnant people. Is the statement informative? Why or why not? It is not informative. It is not helpful because we don't know what the time frame is. 1 year, 1 week, today, 10 years ago? We don't know what the population is. Is it Ann Arbor? Is it Michigan, the US, the whole Earth? So instead, we need to assign a time frame. Let's say that this represents the year 2017 and a population, pregnant people in Ann Arbor. And in Ann Arbor, there were about 1,000 births in 2017. And stipulate that that whole population is at risk. That is, none of those folks got their flu vaccine, or it was one of those bad vaccine years. So among 1,000 pregnant people in Ann Arbor in 2017, 100 developed flu. This is a lot more informative. It gives us the when, where, and who. And if we were being very epidemiology about it, we would report it like the incidence of flu among pregnant people in Ann Arbor in 2017 was 100 cases per 1,000 pregnant people. This is a rate. So because we have the time component, the defined population, and the counts of events over that time period in that population. Measures of association build on measures of occurrence. We use these ratios to determine the associations between exposures and outcomes. It takes the form of occurrence among the exposed divided by the occurrence among the unexposed, where the occurrence can be incidence, prevalence, risk rates, odds, any measures of occurrence are fine. A ratio can be interpreted as approximating the risk of a disease given exposure to some variable of interest. So a ratio greater than 1 indicates higher risk among the exposed than the unexposed. A ratio less than 1 indicates lower risk among the exposed than the unexposed, and a ratio of 1 indicates no difference. A scenario that might produce a ratio that's less than 1 is when you're looking at a positive exposure. So vaccination, you would expect those exposed to a vaccine would have a lower rate of an infection than those who were not vaccinated. So an example of a measure of association. So we have data on teen births for the state of Michigan for 2017, and I've been asked whether race is associated with the teen birth rate. So here's a table with the relevant data. These are relevant data that you can, in fact, get from the MDHHS Vital Records site, including these rates here. So the rates were calculated by dividing the live births by the population over this year, and we come up with these numbers. So the first thing that you might notice is that white teenage girls did have more births in a count sense, right? 2,500 is higher than 1,700. But when you look at the rates per thousand, there's a really stark difference there that's not the same as the direction of the counts of births. So what we would do is divide the Black rate by the white rate, or you can do it vice versa, but typically the higher number goes on top. And we find that Black females ages 15 to 19 were 2.8 times as likely to deliver a live birth as white females ages 15 to 19 in 2017. So that's a lot. That gives us a sense of what the risk is in this specific population at this time in the state. This value is known as the incidence rate ratio, or IRR. Incidentally, this ratio is statistically significant at p less than 0.01, so this is very likely a real difference in these two populations. So you may be wondering why all of the epidemiology interpretation sentences are so wordy. Well, in normal human conversation, you might hear words like risk and odds bandied about all willy-nilly, but we've gone over the epidemiology brainwashing thing, and it's true. So a good epidemiologist writing about a measure of association will include things like the populations of interest, the measures of occurrence, the time period of interest, and end up with just a massive sentence like, among females ages 15 to 19 who delivered a live birth in Michigan in 2017, non-Hispanic Black mothers had 1.43 times the risk of delivering a low birth weight baby than non-Hispanic white mothers, p less than 0.05. That's a thing you would see in an epidemiology publication. And that specificity is it's just unfortunately we can't get around it. It's important to be clear exactly who, what, where, and when the populations of interest are. Because this number may not apply to older mothers, to different years, to different states. So all of those conditions do need to be included. You don't want people thinking that this 1.43 just emerged out of the ether. This is a real number that reflects a real population. So now that we know a bit about where to get data and how to analyze them, we can talk about how to apply them to your work. One thing that I like to harp on is holistic data collection and management. The way that you integrate data collection and management into your practice is to think about what you need from the beginning and have it available to you and at hand to manage and analyze as needed. So some things to think about are where you can get the data to learn, who you're trying to serve, what some of the issues your community is facing are, what services they need, what services are actually being used, what improvement you're seeing in your patients, participants, et cetera, and what improvements that leads to in the larger community. So if you know what data you're trying to get at, you can start thinking about how you would go about measuring or collecting those data, where you could get them from. The earlier in the process you can determine what to measure and how, the easier every other step in the process becomes. Spare yourself the pain of frantically running last-second surveys because you forgot to ask something crucial from day one. I know this pain. Please spare yourself. It is not fun. It is expensive and not reliable. Practice good data hygiene. Data hygiene and clean data are terms used to describe taking a systematic approach to maintaining reliable, accessible, functional data sets. Irrespective of where you get your data from, you want to keep them in good running order. A clean data set should have no errors or duplicates, be properly formatted for analysis, address outlying and missing values, and so on. Excel is not an adequate data management platform. This is because the changes are invisible. I can delete a column or a row of data in Excel and no one will know why or how it happened. They might not even know it happened unless somebody is keeping some sort of outside log. It's preferable to use Access, SAS, or R, which do maintain records of how data were changed from their original forms. No matter what system you use, so if you are using Excel, do maintain some sort of log, even if it's just a Word document or another sheet in your Excel file to say, you know, on December 3rd, deleted this row, just so you can know what happens. But no matter what you use, the most important things to remember are always keep an unchanged version of your original data to check against later edits. This is called quality control. Maintain a record of how changes were made so that you can see where issues may have arisen from. Those two things by themselves will do a lot in making sure that you don't have an error-filled data set. And simple analyses can tell you a lot. You can compare the mean values between two groups, which will help you identify possible health disparities. It suggests intervention points in a community. And you can do significance testing in Excel. The t-test function will do that for you. You can run a correlation between two variables, between age and outcome, or between years and outcomes. While this doesn't identify causal factors, a correlation provides evidence that two variables are associated. And this can also be run in Excel. You can also plot data over time to visualize trend, if not to test for significance. The next slide, which I'm not going to read, but which you'll have access to, does provide other handy Excel formulas, like this. So getting more from your data, augment your routinely collected data with publicly available data. Here's an example that I made of data using both MDHHS vital records data and the American Community Survey. This is a little bit complicated and I'm not going to get into the details, but I basically used data to create data from the ACS to learn where areas of high need were. And I used data from the MDHHS vital records to find the 5-year low birth weight rate by census tract to basically find areas that were both high need and had high rates of adverse health outcomes, and then brought those two together into one comprehensive image. And this work can be done at the county and local health department scale. This map was done at the census tract scale, so it can get that fine a level of resolution. Here to help, your friendly neighborhood epidemiologist. You can request data and analyses from MDHHS. We are a public service, and our aim is to improve the whole population's health across the state. Data requests can include statistical analyses, summary tables, charts, and geographic mapping of exposures and outcomes. For child and adolescent health data requests, you can contact me at townsl@michigan.gov. If it's not child and adolescent health data as such, I should be able to help you find the right person. Data requests can take some time depending on the data requested, so do be aware of that. It is the government, so we have a lot of rules and such. So I just want to thank you for your time, and at this time, if anyone has any questions, I'd be happy to answer them.
How do they ask questions? Can they unmute their line, or is there a chat feature? I don't know.
So you can either input your questions into the chat button or feel free to unmute yourself if you have connected your phone audio. We have one question that's, can you give a really quick rundown of weighting that's done in a data set?
So weighting survey data can be a really complicated process. It typically involves having a comparison group. So you might take, you'll have your survey data for, let's say, for a county. And you know that you didn't necessarily capture everyone in that county, but you do have results from your survey. So you might compare those data to distributions of the population within your county. So for example, if you know that your county is, has 30% of the population is African American and 60% is white and 10% is distributed among Asian American and Hispanic or something like that, you would then take your data and sort of, once you run your results, weigh it so that it better matches the populations within your county of interest. And that does record, that is a little bit of a statistically complicated process. People who write surveys and do survey weighting, you know, it's one of the things. So for example, PRAMS, the PRAM survey, the Pregnancy Risk Assessment and Monitoring Survey that's done through MDHHS, they rely on going to an academic survey design group in order to make sure that their survey weightings are actually correct rather than trying to do it on their own. But for some of the larger data sets, so for things like YRBS and BRFS, they come with weighting variables included within the data set. So as long as you incorporate those into your statistical coding, you don't have to go into the nuts and bolts of trying to make them your data representative of the population as a whole. Does that help? I'm relying on Lauren to.
Excuse me.
What happens if I click where it says more? I don't just, oh, yeah. Look at that.
Yep.
Oh, good. Should I not show everyone? They can see this, right?
No, they can't.
No.
No, it doesn't. No, like they
Oh,
only see the
okay.
PowerPoint. So it's fine.
I want to make sure that the chat room is like a safe zone.
Other questions, or you can also unmute yourself and ask a question over the phone as well.
Or if something occurs to you later, you can feel free to email me. My email is in the slide deck. Well, that's very satisfying for me that everybody is now comfortable with epidemiology and statistics, and you're very welcome.
Well, it looks like there's no other questions, so we want to thank you so much for joining us today. And we are recording this, and so we'll get a recording available. Actually, the local MCH team is working on getting a local MCH website in the next few months, so we'll be able to upload those on our local MCH website in the future as well. So again, thank you. And if you have other questions, feel free to reach out to Lindsay, and she'll be able to help you by email, or if you need to contact the local MCH team by our email, we can also help link you to what you need. So thanks so much. We're ending a little bit early. We had a lot of time for questions, but it seems that you are all very astute on epidemiology now.
We're just very overwhelmed.
So thanks so much and have a great afternoon.